Well, good morning, everybody, and good morning, anybody who may be online. I'm pleased to welcome you to this session, which is called Aid Effectiveness Perspectives from the Health Sector. My name is Arve Ofstad. I'm now doing some work for the European Commission. I'm attached to the consultancy company Ecoris. But I'm not to speak here for very long. We have four interesting presentations. They will have their 15 golden minutes each, and to be followed by a question and answer questions and comments as the other sessions have done. And I have noticed by reading the papers that we have a special treat for you today, in that two of the papers are very similar in the issues they are raising, the data that they are applying, and the methodology, but in two different countries. So the question is, are their findings also similar? Wait, and we'll hear. The two other presentations also raise interesting and important issues, rather differently ones. One is on aid for combating COVID-19 in a fragile country. That's the first one we will listen to. And another one is on monitoring of medicine theft. Monitoring it, not committing it, but undertaking it. So let's begin. I think we have online Mr. Hani Besada. He is a senior research fellow at the UN University, not wider, but the Institute for Natural Resources in Africa. And is also a senior research and program advisor at the UN Office for South-South Cooperation. And thirdly, he is a senior fellow at Billy Graham Center for Contemporary International History at the University of Toronto, and a research fellow at the China Institute for South-South Cooperation in Agriculture. I think he's also got more positions, but we will be very satisfied to listen to him. So I'll leave the floor to you, Mr. Besada, please.
Thank you very much for the opportunity to speak to you today, and I sincerely apologize for not being there in person. I've not been feeling well since my arrival in Brussels, but I thought to make a presentation here and obviously to receive your feedback and questions, and happy to engage further. So today I'm going to be doing a presentation on development aid in fragile states, investigating the effectiveness of COVID-19 aid in Democratic Republic of Congo. I hope you can see my PowerPoint. Here's the PowerPoint. Okay. Next slide. Great. So basically the outline of the presentation, I'm going to be very briefly speak to state fragility, the context of state fragility and COVID-19 outbreak in DRC, analysis of the impact of COVID-19 in the country, COVID-19 aid responses in DRC, framework for assessment of the effectiveness of COVID-19 aid in DRC, and in terms of the way forward. Next slide. In terms of providing some context, state fragility and COVID-19 outbreak in DRC, the OECD projected that 1.8 billion people live in fragile states, projected to increase to 2.3 billion by 2030. A fragile state or region possesses weak institutions and lacks political will and capacity to perform basic government functions at securing and safeguarding citizens' lives and properties, in terms of also overall reduction and overall development. Fragility goes beyond conflict and encompasses a wide range of unstable situations, including disease outbreaks, climate change, food shortages, environmental disasters, economic downturns, and in this case, also health challenges. The evidence of seen armed conflict and human rights abuses and job losses. In sub-Saharan Africa, COVID-19 pandemic aggravated the situation as more than 13.5 million people have lost their jobs due to the pandemic, and 95 million workers were pushed into extreme poverty, with about 278 million people affected by extreme hunger. The numbers are set to multiply once figures come in from 2022. It's projected to be even more dire. Next slide. In terms of state fragility in DRC, the speed of fragile states necessitates the urgent need for international community to act fast and decisively in addressing identified challenges. Some of these efforts include SDGs, New Deal engagement in fragile states, the OECD DAX principles of good international engagement in fragile states. All these principles and uses are important to take into consideration. It offers guidelines in terms of policy guidance and policy development for development agencies to act effectively in fragile states. DRC is a typical example of a fragile state. Continues to experience continuous cycle of violent conflict, although being endowed with natural resources spanning from 70% of the world's cobalt reserve, 60% of global cotton reserve, fourth biggest producer of copper. DRC has more than 80 natural resources, although it still continues to be one of the most fragile affected states. Next slide. It has a history of his authoritarian rule, political upheaval, ethnic strife, and civil wars that put the country on the brink of collapse every so often years. DRC remains one of the poorest countries in the world, with 73% of its population living in extreme poverty, representing 60 million people living under the $1.9 a day benchmark. The Human Development Index ranked the country as extreme poor, 164 out of 174 countries. Fragile State Index ranks DRC as the sixth most fragile state out of 179 countries in the world. That gives you a sense of where we stand with DRC. Next slide. With the country having a great deal of experience in dealing with previous disease outbreaks such as Ebola, cholera, and measles, COVID-19 outbreak has handicapped the country's healthcare system, already very vulnerable, putting lives of many of its citizens in extreme danger. COVID-19 pandemic exposed and escalated the fragile nature of DRC, including its weak institutions, poor healthcare systems, and insecurity. Examples are seen in significant drop in the number of citizens that could access healthcare facilities, 16% reduction of hypersensitive patients, 39% of reduction of diabetes patients visiting the healthcare centers. Next slide. The unavailability of PPEs such as gloves, surgical gowns, hand washing kits, protective clothes, infrared thermometers in healthcare centers, gaps in skilled medical personnel to handle the pandemic, among other, resulted in more fatalities coupled with overstretched healthcare system due to the previous diseases such as Ebola. Economically, the pandemic has been more of an economic crisis than health due to the disruption of economic activities, with existing unemployment rates and poverty rates put at 46.1%. There was 6.2% and 0.2% of GDP contraction in 2020 and 2021, respectively, as a result of the pandemic. Next slide. COVID-19 aid responses DRC were both internal and external. Internal, the government of DRC took some decisive measures to mitigate the negative effects of the pandemic. These efforts were firstly announced as a nationwide lockdown on March 26, 2020, with an order to close all the borders. Others include supporting household demand for basic necessities, providing fiscal and monetary measures to support citizen socioeconomic activities, provisions of economic stimulus packages, creating funds to support spending measures relating to the pandemic crisis, supporting the revival of companies' activities through financing from the Fund for the Promotion of Industry at zero rates, providing credit to food and pharmaceutical companies, while prohibiting mass dismissal based on lockdown measures. So the DRC Congo has taken concrete measures to mitigate the negative impact of the pandemic, to its credit. Next slide. As mentioned, there's been a number of donors, international development partners that have come to the aid of DRC, most predominantly China. Externally, the country has received a series of support in terms of development assistance. China has granted a debt relief worth of $2 billion to southern countries, in particular 28 million debt relief for Kinshasa, to effectively combat the virus. This is in the context of South-South cooperation, which has become an important aim of mitigating and promoting cooperation between developing countries to promote development, sustainable development. Granted, no less than 53 loans totaling 2.4 billion to the DRC took place between 2000 and 2018. As a result, the country would not be required to pay back interest-free loans it received from China that were due to expire at the end of 2020. Additionally, 400,000 doses of Sinovac, the Chinese COVID-19 vaccine, were donated to the country. In later part, donations were an integral part of the bilateral agreement between the two countries to ensure equitable access to vaccines, which is an important facet, an important criteria and requirement put place by the DRC government in terms of its relationship with the Chinese government. Next slide. Obviously, the West has also come in to the aid of DRC. Most importantly, the United States and the United Kingdom and France. With respect to the United States, the US has provided the Congolese government with increased dosage of the COVID-19 vaccines at no cost, nearly 4 million dosage. This includes Johnson & Johnson, Moderna, and the Pfizer dosages. While the UK government has also provided, thanks to a bilateral gift from the UK, and the COVAX mechanism, a collaboration between the Coalition of Innovations in Epidemic Preparedness, Gavi, UNICEF, and the WHO, more than 51,000 dosage of the AstraZeneca vaccine. Next slide. France, its historical partner in the West, former colonial partner, has also come to the aid of DRC, received a 1.2 billion in terms of Health in Common Response Initiative for African countries that was launched by the French government under the auspices of the Agence France de Développement to strengthen African healthcare systems during the pandemic. And DRC Congo had been part of that agreement and has taken advantage of the development aid that has been provided under the agreement. The initiative's primary goals were to support major French COVID-19 actors, such as NGOs, foundations, networks, research bodies, and provide financial support for the reinforcement of healthcare systems, and to contribute to the national COVID-19 reaction plans in African states. Next slide. From the IMF, at the peak of the pandemic, the IMF has partnered with intergovernmental coalitions to give emergency loans in terms of to form upfront cash payments launched within the context of the IMF WHO COVID-19 vaccine tracker, the WTO IMF COVID-19 vaccine trade tracker, the COVID-19 Global Targets Progress Tracker, ACT MLT Cobalt COVID-19 Access Tracker. All these initiatives have been put in place by the IMF to help in terms of cash advancements to countries that are affected by COVID-19 pandemic. Next slide. In terms of UNICEF and the European Union, the EU flight convened a shipment of UNICEF 3 times to Goma and Kinshasa, containing 3.7 cubic meters and 183 cubic meters of essential health supplies to the country. In partnership with COVAX, an alliance comprising of Coalition of Epidemic Preparedness Innovation, Gavi, Vaccine Alliance, and WHO, UNICEF has provided 1.7 million doses of AstraZeneca vaccines to Kinshasa. Many people were reached with critical water hygiene supplies, such as water treatment, water containers for safe storage, and soaps. These are very essential equipments and products that have been provided in the context of strengthening health systems. Next slide. In terms of assessing the effectiveness of the pandemic aid in DRC Congo, no doubt COVID-19 has played a huge role in the country's response to both health and economy, but due to the significant contribution to the global effort in combating the COVID-19 pandemic. Before now, there have been international principles, frameworks guiding aid effectiveness in fragile states. This includes the SDGs, OECD principles, the IDP New Deal for Engagement, which is a G7 plus group of countries, which includes very fragile affected states, of 19 agreements with international organizations and development partners. The focus has been in terms of evaluating health and non-health related priorities around COVID-19 aid to DRC Congo. Next slide. International agreements in fragile and affected states situations are expected to abide by these principles and engage in local stakeholders with a sense of sincerity. In the case of DRC, which is a traditional aid recipient country, and a typical fragile states, these principles are expected to serve as a guiding template for international donors during this unprecedented times during the COVID-19 outbreak. Taking context as a starting point, donors need to understand the realities of recipients' country through baseline studies, for instance, their capacity, political will, legitimacy, prolonged crisis of impacts, etc. China, in specific, understood this and giving grants vaccines to DRC, canceling debt worth of $28 million. DRC has opened up its economy to the global trade by receiving 400,000 dosage of the Sinovac vaccine from China. Next slide. In continuing with the principles and frameworks, ensuring all activities do not do harm. Undoubtedly, international interventions are susceptible to causing unintended harm. However, donors need to be more rigorous in terms of monitoring funds donated to DRC Congo, especially as the country has a long history of chronic corruption. As a result of this gap, COVID-19 aid funds were embezzled by the former Minister of Health, who was arrested for misappropriating more than $7 million in terms of aid that was given for vaccines. Prioritizing prevention, putting in place preventive measures is extremely important to avoid disease outbreaks. It's worrisome that a country like DRC has experienced several disease outbreaks from cholera, Ebola, measles over the years, but has failed to build a resilient healthcare system that could withstand future pandemics and outbreaks. For example, majority of donations to DRC are in the form of vaccines, loans, grants, technical support. There's little focus on creating a resilient healthcare system and capacity of health personnel. Next slide. In continuing with the principles and frameworks, aligning local priorities in different ways, in different contexts. Donors should align their aid programs with local priorities. The synergy would drive stability in fragile states such as DRC. And acting fast, but staying engaged long enough to give a success a chance. Sustainable broad-based development takes time and perseverance. International donor actors should commit adequate human capacity and financial resources to support transitioning process of fragile states. States and non-state actors respond to these challenges out of shared responsibility to drive global stability, following all the stated principles that may be somewhat unrealistic. The primary responsibilities of local states should not be put on donors, and that's important to take into context. Next slide. In terms of the way forward, it's evident there's been successes and gaps identified in the series of COVID-19 aid from varying list of donors, including China, debt relief, the United States with vaccines, the IMF credit facility, and France, as well as COVID Health in Common Initiative to DRC Congo in trying to combat the virus and to help the country recover economically. However, the reality in DRC revealed that there is a need for foreign donors to gleefully abide by the OECD DAX principles. Thus, the following recommendations by the study. An effective monitoring evaluation system is needed. Donor partners must strive to use the detailed monitoring evaluation framework to evaluate the success of the development aid programs in fragile states and situations. Next slide. Adoption of preventive measures rather than reactionary responses are needed. Donors will need to pay more attention in creating strong political institutions and resilient healthcare systems that could withstand future disease outbreaks. COVID-19 is not going to be the first and only outbreak. We need to prepare for future outbreaks, as well as provide technical and financial support preparing in any future outbreaks that may occur. Next slide. That's all I have. Thank you very much for your attention. Look forward to your comments.
Thank you very much, Mr. Besada, and maybe thank you in particular for reminding us of the principles for developing cooperation in fragile states. We will have some comments and questions to you towards the end here. Now, I'd like to invite the next presenter, Ann-Sofia Isaksson, from the University of Gothenburg, or Universitet i Göteborg, I think they say in Swedish. She is attached to the Research Institute of Industrial Economics and a long-time researcher on development economics. She's going to present this paper on aid and child health, local effects of aid on stunting in Malawi, which she had written together with one of her colleagues, I believe. So let's listen and watch what she has to say, please.
And this is on, right? Yeah. And that works as well, which is great. Okay, so thank you very much for the introduction. So I'm going to present a paper on aid and child health in Malawi, looking at the local effects of aid on stunting. And as mentioned, this is joint work with Dick Dureval, who is also at the University of Gothenburg. I'm not used to using this one, I'm afraid. So I'm going to be like this. Sorry. Okay, then. So the aim of the paper is very straightforward. As the title implies, to investigate the local impacts of aid on stunting in Malawi. Specifically, we seek to investigate whether aid projects help to reduce stunting in the local area around project sites. We are also interested in when the potential treatment effects actually kick in and for how long they last. And also if they vary depending on treatment intensity, the type of projects and the type of donors involved. So stunting is commonly defined then as a height for age that is more than 2 standard deviations below a commonly agreed upon growth standard. So why is this an interesting outcome to consider? Well, basically it is seen as a good marker of child health in a more general sense. So it captures malnutrition, but not only that, it also captures child health in a more general sense, as I mentioned. So it is an irreversible outcome that is mainly due to inadequate nutrition, but also due to repeated infections during early life. So in particular, the 2 first years of the child's life are seen as especially critical for stunting. And children who are stunted have documented negative effects throughout life in terms of diminished cognitive and physical development, in terms of reduced productive capacity, poor health outcomes, increased risk of chronic diseases, and so on. So a strong marker of child health in a more general sense then. If that was not enough to convince you that it's an interesting outcome to consider, it's also part of the Sustainable Development Goals, as as most other things that we look at these days. The zero hunger goal has one of its main targets. One of its targets is to reduce stunting by 40%, if I remember correctly, among children under 5. Okay, so this heat map paints a familiar picture where, you know, sub-Saharan Africa and parts of Asia are most hard hit by the problem we're studying. So here Malawi, the country in focus today, is one of the dark red countries with prevalence rates of around 40%. So we're considering stunting in a high prevalence country then. Okay, so the contribution of this paper, it's the first study, to our knowledge, using geocoded. I had to add broad-based aid data because we have another presentation in this session focusing on water and sanitation aid, right? And outcome data to study the local effects of aid on impaired child growth in Africa. So as such, we contribute to this literature on aid and health outcomes, which until recently have focused mainly on country level, on the country level relationship between aid and different health outcomes with mixed findings. So we're thinking a finer lens may be needed. So compared to country level studies, we think we should be better able to deal with causality issues, since we're able to control for unobserved factors that may bias our estimates at a local level. We're also able to disaggregate aid by sector, by type of donor, and so on. At the country level, it's common to aggregate over aid flows that may have very different effects because they were given for different reasons. So we're going to consider aid in an aggregated fashion, but also try to break it up by sector and donor. And you can also account for heterogeneity within countries then, obviously. Some aid effects in local areas may not be big enough to be picked up at the country level, basically, while they're still important in the area targeted. Okay, so our study will contribute to this growing literature evaluating subnational effects of aid using geocoded aid and outcome data, and this is very much thanks to, you know, the work of aid data that Anke Höfler mentioned yesterday. So I've been writing some stuff in this field myself for the last couple of years, but there's not that much done on aid and health outcomes. And looking at aid and child health outcomes in particular, then we have a few papers on infant mortality. We have a paper by Rustad and co-authors on agricultural aid and wasting among children due to drought. And we have a paper in this session that will be interesting to listen to, for sure. Okay then, so to investigate these questions then, we geographically match geocoded data on aid flows from aid data to Malawi with survey data from the DHS. And we focus on kids under 5. So we have a sample of just below 27,000 children under 5. And we have to restrict our attention to aid projects that actually have a tangible project sites and that can be geocoded with relative precision. So with that in mind, we are left with 778 aid project sites. So I don't know how well you can see this, but the aid project sites are in red and the DHS survey clusters are in gray. And we use the point coordinates in the aid data then to link aid projects to survey respondents. So basically, we identify survey clusters that are located within a cutoff distance of at least one project site. So as I mentioned, we focus on stunting, a height for age study score that is less than 2 standard deviations below this growth reference standard, the child growth standard of the WHO, to get a sense of conditions for the most vulnerable children. We also consider extreme or severe stunting, and also to get a sense of not only the variation around these specific cutoffs, but along the full spectrum. We also consider the continuous height for age Z score as an outcome variable. But today I'm not going to be able to have time to present for all these different outcomes. But as it turns out, they're very similar, the results for these different outcomes in most part. Okay, so in terms of treatment or aid exposure, so we want to capture if a child is exposed to aid during this critical period during its early life. So I've already mentioned that the first 2 years of a child's life are especially critical. So why not just consider if you're exposed to aid during these, if you have an aid project starting, if you're born 0 to 2 years after an aid project start. Well, basically, we know when project implementation starts, but we don't know really when projects are up and running and when the benefits actually reach, intended beneficiaries. So we allow for a small lag here and consider our benchmark treatment variable indicates if a child was born within 0 to 3 years of the start of a project. So 0 to 3 years after a project starting and we use a 10-kilometer cutoff in the benchmark specification. But we treat this, we're admittedly, agnostic to the geographical reach of this potential treatment effect. So we consider different cutoffs, and we also consider different year spans and try to be transparent with that and present results using different cutoffs and for different year spans. Okay, so the identification problem is familiar, right? Not only is aid not distributed at random across countries, it is not distributed at random within countries either. So to deal with this to the best of our ability, we rely on spatial and temporal variation in aid project coverage and survey rollout, coupled with variation in child birth years. So we have cluster level variation in aid coverage, which depends on aid allocation across areas, which is of course subject to selection, but also on when the area was actually surveyed in relation to project start, which should be more random than in a sense. But we also have child level variation in treatment or treatment intensity or whatever you would call it. Since your early life aid exposure depends on how old you were when the aid project started. So when you were born in relation to project start then. So the identifying assumption then would be that conditional on area by survey year fixed effects and child family characteristics when the child was born in relation to possible project start is near random. So to further convince you and myself about this, we consider different samples. In a stepwise procedure, we restrict the sample. So in the full sample, we rely on area by survey year fixed effects. And then we restrict the sample to clusters that at one point or another have been chosen as aid project sites. So they've had a project in the past, they will have a project in the future, or they have a project now. So this should reduce the issue with, selection issues to do with the area being deemed as an appropriate aid project site. So we compare only within these ever-treated clusters. So far so good, but Malawi is a relatively small country area-wise, and it's there are a lot of aid projects around. So this first restriction is only, I mean, it's basically 75% of the sample live in these types of areas. So in a final step, then we restrict the sample further to include only treated children, so those born 0 to 3 years after project starts, and we compare them with kids born 2 to 4 years ahead of project start, 2 to 4 years rather than 1 to 4 years, so as not to contaminate kind of the control group then. So this is our benchmark specification. It's a very straightforward OLS with a treatment dummy specified in the different ways I mentioned and the different outcome variables I mentioned. So turning to the results, well, basically we find that a consistent result is that children exposed to aid during this early period are less likely to be stunted. So this, here we're using the regular stunting variable as outcome variable. It is not a huge estimated effect, but it's consistent and it becomes more pronounced the more we take account of selection rather than the other way around, which is always reassuring. So this is kind of our main finding. And then we do a bunch of other stuff. So here we try to get a sense of when the treatment effect kicks in. Is it 2 minutes? Yeah. 2 minutes left, okay. So when the treatment effect kicks in, and we see that, you know, it fades after, if you're born like 4 years after, there's reassuringly no effect of being born 2 to 4 years ahead of project start. We also consider treatment intensity, the number of projects you have in the vicinity. More is better, seemingly, but no clear linear pattern. We break it down by sector to see what type of aid could be driving the result. We see that aid going to education, vulnerability, rural development, and also to infrastructure comes out positively. Somewhat surprisingly, nothing on water and sanitation or agriculture or health, which we would expect. It seems to be driven by multilateral rather than bilateral aid. We also break it down by single donors, but it's a bit difficult because so many donors are active in the same areas. But it seems to be driven by multilateral aid with the World Bank and the EU at the forefront. We do a bunch of robustness and heterogeneity, and we have some preliminary analysis when we look at mechanisms. But to conclude, do aid projects help to reduce stunting in the local area around project sites? Yes, it seems so. Not a huge effect, but it's consistent throughout our estimations. We see positive effect for kids born at the same year of the project, of project implementation start, and lasting until around 3 years after. And this, that it fades when they're like born 4 years after, that may seem a bit disappointing, but you can think about that. Since stunting is an irreversible outcome with long-term consequences, at least for this cohort, for the cohort of kids that are actually affected, the effects could last a lifetime and save them from negative consequences of a lifetime. Yeah, I think I've said most of this quite recently, so yeah, that's all. Thank you.
Thank you very much, Anne-Sophia, for not only an interesting but also encouraging paper. Aid projects do work in some areas. And but we'll turn to the next third presenter, Ryan Jablonski, who is going to, who is an associate professor, I believe, at the London School of Economics and Political Science. has a PhD in political science, and he's going to talk to us about the effect of top-down monitoring of medicine theft. Please, go ahead.
Thank you very much, and thanks for joining. So today we get to talk a lot about my favorite country, Malawi. I'm going to give you another presentation on Malawi with a somewhat different focus. So what I'm going to talk about today is problems of theft and corruption in Malawi's health sector. So, if you've been around health sectors for a while, this is a big issue in a lot of low-capacity contexts, where a lot of audits around the world suggest, for instance, in Malawi, that around 30 to 40% or more, I'll talk about that in a second, of medicines go missing from the point of delivery to end-user clinics or end patients. But those numbers are not particularly extreme. We find similar numbers in a lot of other countries, including Nigeria, South Africa, the Congo, or the DRC rather. And what I'm going to try to do, what we did with this project is introduce a pilot of what we're going to call electronic audits as a way to measure corruption within the Malawi health sector, and also as potentially a way to reduce it. And I'm going to try to convince you of three conclusions from this site. So this is a project we've been working on for several years with some technology partners and the Ministry of Health, as well as FCDO, the ACE Integrity Program, and the World Bank. And I'm going to try to convince you, using the information from the study, of three basic conclusions. One is that medicine theft is a big problem for public health. It has quite large impacts, but is perhaps not as severe a problem as you might think if you spent a lot of time in the literature and reading the news on public health corruption. I'm going to argue that a lot of what we see as corruption is actually mismanagement, and I'm going to give you some, what I think, fairly convincing data of this. Second, I'm going to try to give you some, try to convince you that our traditional technologies, paper audits, oversight institutions, bottom-up monitoring that we use to prevent theft don't work. And it doesn't work for very systematic reasons that exist in most countries, which is that most theft in the health sector is very bottom-up. It's not top-down, it's not observable through traditional audits, and it's not preventable through traditional types of interventions. Finally, I'm going to try to convince you that the technological innovation that we introduced in this pilot study, namely using electronic audits as an alternative to paper audits, is a way to solve some of these problems. It's not perfect, I'll talk about that, but has some solutions that address some of these challenges, and is potentially a way forward for this anti-corruption program. So why should we care about corruption in the public health sector? I think I probably don't need to convince this crowd, but of course there's huge amounts of economic waste that occur. So if we look at Malawi, for instance, we find that about a third of Malawian medicine budgets are lost due to corruption. Those are government numbers, those aren't auditor numbers. The two numbers may or may not be higher, depending on who you ask. Globally, the numbers, they're blindfolded, but the estimates suggest about 25%, 10 to 25% of health spending is lost to corruption. This, of course, again, very difficult to estimate, but if you look at the correlations, this appears to have large impacts on public health. It's related to stunting in Malawi, as Anne-Marie can attest, but it's also related to a lot of other, it's related to stockout, access to medicines, poverty, lots of other impacts. And also, and I'll give you some evidence for this in a second, it's related to poverty, that places with high poverty tend to have higher levels of corruption, but it's also evidence that individuals, particularly there's some good evidence from some studies in South Africa looking at rollouts of medicine deliveries and identifying stockouts, showing that this has quite a large effect on poverty, because it's particularly those at the lowest end of income the spectrum that can't afford to go to private facilities when their local government facility doesn't have medicines that they need as a result of corruption. So, how much corruption is there in the world? If we look at public audits, there's studies in Malawi, in Uganda, saying about 73% of medicines go missing in public audits. That's an older number. The numbers are probably better now. In China, 30%, 75% of clinic officials are aware of theft. There's some interesting studies in Uganda showing that, and I think this is true in Malawi as well, that a large portion of the income for public health officials comes from corruption. And this is, I think this is true in a lot of contexts where public health officials aren't paid very much, and where corruption is relatively easy to engage in. So we have estimates. Malawi, we have 95% of facilities having bad paperwork, 35% of medicines markets having stolen drugs. So across lots of different countries, we have huge amounts of theft. But I'm going to try to convince you that we really don't know. And we really don't know for a couple of reasons. One of the main reasons is the main way we try to identify theft is through an audit, right? We have some individual that physically goes to a public health facility, picks up a box that looks like this, in the case of a lot of Malawi clinics, and tries to figure out whether or not medicines that were supposed to have been delivered to a clinic are actually still in the clinic and where they're supposed to be on the shelf. We had 3 PhDs go through that box and couldn't figure this out. So I would challenge you to try to do this effectively. And in fact, this is exactly what we find if we look at audit data. If we look at Global Fund data trying to do audits of these, we get statements like this that say, hey, we had 42 health facilities which received medicines. We have no documentation of it. 95% of all health facilities in Malawi, they can't confirm whether or not the medicines are actually at the place they're supposed to be. So these numbers are just pulled out of the air. We really do not know how much corruption there is in the health sector. So what are we trying to do? Well, what I'm going to try to talk about, so first, actually, before I talk about what I'm trying to do, I'm going to say a couple things about why existing interventions and existing measurement strategies do not work. So usually what do we try to do when we try to prevent corruption? Right, we try to do some kind of audit that looks at whether or not medicine that left a government warehouse ended up at a health facility pharmacy, right? This is what an audit does, right? You show up at the health facility pharmacy, see whether the medicine actually arrived, whether the documentation matches. There's a number of problems with that with the documentation, but there's also a kind of assumption about the model of corruption here, which I'm going to push back on, right? The assumption is that what happens, the corruption that happens, is some person, either at the government warehouse or in the delivery company or as part of the delivery process, takes medicine and goes and resells it. And this is what, kind of the bottom-up Svensson-style monitoring does, tries to prevent this, right? Have community officials go and observe deliveries. This is what audits do, right? Almost all the investment that we do in public health corruption is focused on this. In Malawi, this is what this looked like. There's a private company that does pharmaceutical deliveries. This is the government warehouse. But what if that's a mistake? What if corruption is actually decentralized? What if it's the case that most theft happens not between government warehouses and health facilities, but happens downstream, right? What happens after the medicines get delivered into a pharmacy? What if the theft that's going on is public health officials then reselling out of public facilities at the clinic level, or after it goes to treatment wards within hospitals or clinics? So this is some pictures of wards and pharmacies within Malawi. And I'm going to give you some evidence that this is the predominant form of corruption that we see, at least in the case of Malawi. How are we going to do this? So what we did is we used what I'm going to call electronic audits. What these are is a technology that's been used in a lot of different countries to track valuable pharmaceuticals. So this particular company, On Acid, they do most of the delivery, for instance, of Pfizer vaccines within the United States. Where they're a procurement tracking company. And we partnered with them to try to use their technology as a way to identify corruption. So how did we do this? Basically what they provide is they provide a little device about the size of a credit card. Now they've gotten even smaller. They're basically a little barcode. And what we did is we basically placed them on 2,300 medicines leaving government warehouses during several months of delivery in Malawi. And what these devices do, they're effectively a long-range Bluetooth device. They have a range of about 300 meters. They communicate with a larger parent device, which sits on a delivery truck, or as I'm going to talk about in the case of our electronic audits, sits in a backpack of one of our auditors. So what we can do with this is we can use this to identify in real time where every single of these medicines are that we're tracking, and whether, once they arrive at a clinic, whether they're actually staying in that clinic. What I'm showing, so we're going to do this. We do this in southern Malawi. This is a map of southern Malawi. All the places we worked. We're working in all the government clinics in southern Malawi. I'm just going to talk briefly about what we did. So if you think of the way that Malawi medicine procurement system works, you've got central medical stores in Blantyre down here. From central medical stores, you have trucks, a private company that goes and delivers to health facility pharmacies throughout Malawi based upon procurement orders. And then from health facility pharmacies, we have medicines that go to treatment wards and then eventually to patients. What we did is several things. One is first, prior to the experiment, we did a bunch of surveys and list experiments with patients, trying to identify experiences of theft. How much theft do people observe? How much do people expect? Level of stockouts, that kind of thing. I'm going to use that to validate some of the data that I'm going to collect with the devices. So we're going to run 3 separate audits. One is we're going to do a kind of what you think of as a traditional audit, except we're doing it electronically, which is these delivery audits. So we're putting tracking devices on all the trucks, and we're determining whether or not medicines actually reach the clinic that they're supposed to. Second, we're going to send teams to most of these clinics, 104 of these clinics randomly selected, to do physical audits, right? To show up after the delivery to determine whether or not the medicine that is supposed to be in the clinic is actually still in the clinic. And then finally, we're going to do audits in 143 private facilities and pharmacies, right? So the question is, if a medicine is not where it's supposed to be, is it ending up in a pharmacy or a market that's nearby to the clinic? What does this look like? So our audits are basically individuals that go in person as not as auditors, right, but as kind of undercover as patients, going to different clinics, going to different markets, going to different pharmacies, and essentially walking around with a tracking backpack. These tracking backpacks have a range of 300 meters. Most of these clinics are relatively small. They're basically told to walk around anytime they see somewhere medicines are being stored or dispensed. They wait for 10 minutes. The device automatically picks up all the devices, and they continue walking around. This is because the range of this basically gives us a way to identify, regardless of whether you can actually see the device or whether you can record the device, whether any paperwork exists, we know whether or not a device is actually at a physical location. Okay, now I should say we're not doing all markets and private facilities. The point of this is not to find all of the medicines, but rather to give you some evidence that what we're identifying in this study is actually theft, and we do actually see the resale of some of these medicines. So first, just a quick observation from our baseline survey, which is that this is from a survey experiment, or a list experiment, so basically asking people whether they observe theft within their community, and then we can use that to back out community level probabilities of theft. And basically what you find if you do that is about 80% of communities in southern Malawi have observed medicines being sold within their community. So this is a huge problem. This is basically what it looks like. This is a picture taken by some of our enumerators of individuals selling. That you can tell these are government medicines. If you look at the branding there, they say Malawi Ministry of Health. So those are medicines being sold to market. This is effectively what we're trying to identify. All right, so let me talk a little bit about, am I okay on time?
Well, 3 more minutes.
3 more minutes, okay. Okay, so I'm gonna talk about what we learned from the data then. So what I'm showing you here, I'm gonna give you a few histograms like this. What these histograms are is just the distribution of medicines not delivered. So first I'm gonna talk about what happens during delivery. So during delivery, what we find is that about 90% of medicines are delivered where they're supposed to. And I think we find about 11% are not. Most of those 11% are actually medicines that are delivered in the wrong place. This isn't unimportant, right? So, you can see there's a number of clinics that are not receiving any medicines at all, right? This is important from a public health standpoint. These missing medicines are particularly in very remote locations. I think anecdotally, part of the story here is basically drivers don't want to go and drive out to Nino and deliver medicines in very remote locations. But this is not the main part of the story, right? This is not 30, 40%, 90% of medicines going missing. This is much, much lower than this. And I think this is not surprising. I've spent the last 3 years spending a lot of time in the Malawi procurement system, right? These are independent South African drivers that are coming in, relatively well organized, good paperwork. their incentives, they're relatively well paid, their incentives to steal are not that high. We get a very different story when we start to do in-person audits. We look at downstream, what happens after a medicine has been delivered from a clinic. What happens there, what I'm showing you here is another histogram, where what I'm showing you here is the proportion of medicines that are found after it's been delivered, and we go back and do an audit at that location. And what you find there is that about 31% of medicines never show up at a government health clinic. Suggesting that a lot of what's happening in medicine theft is actually this bottom-up story that we're not picking up through a lot of our traditional interventions and monitoring mechanisms. And again, we're seeing a lot in remote areas, but it's relatively well distributed throughout the country. And then again, this is quite substantively important for a lot of clinics, where many clinics are getting more than 50% of their medicines not being available in their public health facility. So what happens to those medicines? So what I'm going to show you here briefly is our best estimates of where medicines go. So if we don't find a medicine, what happens to it? So you see, we audited 1,781 medicines, which is about 80% of the medicines going to southern Malawi, or 80% of the clinics, 80% of the total medicines we tracked. So random across all these clinics. And what we find is about 28% aren't found. We find about 2% in private markets, about 0.5% at other locations, but about 10% in wrong clinics. So what can we conclude from that? Well, one is this is important, right? We do see a lot of medicines are going missing. Some of these are going to private facilities. This is corruption. This is something that we should care about. But I think this is also a very, I would push back on the kind of extreme stories. Right? This is not a story of tons of medicines going missing, and it's also not a story of all the medicines going missing through corruption. Instead, what we see is a lot of this, right, the biggest chunk of medicines that we're able to find are actually medicines that are just going somewhere else, going to places where they're not supposed to, which we're still going to identify as theft if you think of like a traditional paper audit. Right? They're going to show up, the medicine's not there, oh, this must be theft. No, in fact, what we find in a lot of contexts, and I think Malawi is going to be similar to a lot of other contexts with very low capacity, poor paperwork, not a lot of good management of the procurement and delivery process, is that there's just a lot of mismanagement or poor record keeping that means that medicines aren't going where they're supposed to be going. And this is a lot of what we're picking up. Okay. Okay, I'm out of time. Let me just say, try to convince you that what we're picking up is actually theft. This is just comparison with baseline measures. What we find, it's correlated with more people spending more money on private medicines. It's correlated with people observing medicines going missing. It's correlated with people observing theft in their public health, right? So our baseline survey measures of theft seem to correlate quite well with our electronic measures. Again, these are just correlations. I'm not identifying here, but there is good evidence that this is partially the explanation for a lot of the stockouts and missing medicines within Malawi. What I'm showing you here is the proportion of medicines not traced with our electronic audits and the reported stockout rates from our survey of 3,000 patients. And they're very highly correlated. Places where people observe that they're over the last 3 months that they've gone to their clinic and not be able to get needed medicines are exactly the places where we're finding a lot of medicines going missing. Theft, and of course, what I'm showing you is the theft and stockout rates. Perceptions are also very correlated if you look at citizen surveys. Okay, so what can we conclude from this? One, that a lot of measures conflate poor management with theft. We find, in fact, around 11 to 13% of medicines are going to the wrong place, not being stolen. So theft is high, but not as high as a lot of estimates. In fact, most estimates would suggest. Evidence is not consistent with centralized theft, which I think is a big deal from a policy perspective. Instead, theft is decentralized. It's driven at the clinic level. And then I hopefully have convinced you that technological audits potentially offer not a perfect tool, but a useful tool that addresses some of these monitoring challenges and potentially also could inspire some interesting interventions. And then I've also given you some evidence that there's at least some correlations between theft and health outcomes and public health expenditures that we should really care about. Thank you very much.
Thank you. Thank you very much. I don't know whether this is reassuring or not, but I think it's helped us clarify some of the challenges that we have in order to reduce theft. I do recall in some other countries where sort of disappearance or corruption was growing, and people were sort of saying, you know, it goes to 30% or more, that's really bad, but 10% is enough. It's going to be difficult to reach the 0 percentage. Well, we'll leave the questions to the audience afterwards. And before we do wish to have the final paper here, to presented by Raymond Karaher. Karaher. More English, yes. A PhD candidate, I believe, in the University of Massachusetts in the States. The title is, Does Project-Level Aid for Water and Sanitation Improve Health Outcomes? And the evidence is from the household panel data in Uganda, and I do believe it's about stunting.
Yes.
Please, the floor is yours.
Great, thanks very much. Hello, everyone. Are we good? Let's see here. Can I click? Great. Yeah, so my name is Ray. Thanks so much for coming to the panel. It's great to have an earlier paper on stunting as well. Some of our results, I think, are pretty close. Others are a little contradictory, so it'll be interesting to kind of see what's going on there. So yeah, this is a paper that I co-wrote with my research advisors, Linda Pickboard and Leonce Ndukunama. This is kind of a follow-up project to one we did last year that was published last month in World Development, where we look at the effect of water and sanitation aid on actual water access outcomes. So improved access to clean drinking water and improved sanitation access. And there we find some encouraging positive results. So we wanted to do a follow-up and look at actual health outcomes, which is what we do in this paper, focusing on childhood stunting. Great, so we already covered some of this background information, but in case there's a pop quiz at the end of the panel, child stunting is when the length or height for age is more than 2 standard deviations below the WHO child growth standards. And as, again, we've already talked about, these have long-lasting effects. So reduced cognitive ability, lower educational performance for the child when they're growing up, and in the long run as an adult, lower productivity, lower wages, increased risk of disease. And specifically, sub-Saharan Africa has the highest regional prevalence of stunting. So 32.7%, or 57 million of the children in sub-Saharan Africa are considered stunted. And it's the only region in the world where the absolute number of stunting children is growing, despite overall falling rates. So for some background on WASH aid and stunting, diarrheal and enteric disorder, EED, have been shown to be significant causes of malnutrition and stunting in young children. And this is kind of what gives us the idea that maybe there can be a positive effect on stunting when we look at WASH aid and improved access to WASH services. But universal access to safe water remains elusive. In sub-Saharan Africa, 771 million still lack access to basic drinking water. And further, WASH aid has started to lag relative to total aid disbursements to the region. And this is despite the fact that the majority of sub-Saharan African countries have continued to emphasize that they do not have enough funding to reach their water and sanitation goals for the Sustainable Development Goals. So specifically for Uganda, we found a decline in the relative share of ODA going to the WASH sector by 20% from 2012 to 2015. So I think it's important to continue to do work and emphasize the importance of WASH in health outcomes. So just to emphasize this point further, this figure just shows the relative proportion of people who have access to clean drinking water and basic sanitation services by region. And you can see SSA, just on the far right here, lags far behind the other regions of the world, with 64% only having access to basic drinking water, and only a third having access to basic sanitation services. But there has been some growth. So this just breaks down the same data, but by decade, with the blue being 2000, red 2010, green 2020. And we can see there has been considerable growth in access to drinking water on the bottom panel, so from 45 to 64%. And in people using basic sanitation services, so from 23 to 33%. So these two stylized facts kind of brings us to our research question. So does WASH aid improve health outcomes, specifically the probability of stunting in children? And kind of the way we operationalize this is, are children born 1 or 2 or 3 years after a WASH project, are they relatively less likely to be stunted than children born 1 year before? So that's kind of the empirical strategy we're gonna take. We're gonna use the same kind of data set that we used in our world development paper, where we combine geolocated subnational data on the location of WASH projects, the aid data, which has been used many times in this conference, with 6 waves of household level survey data from the Uganda National Bureau of Statistics. And we use a diff and diff approach to examine the effect of WASH aid on childhood stunting by proximity. And just to briefly summarize the results, we do find substantial initial drops in the probability that a child is stunted, but this effect diminishes as time increases. So if you look at cohorts of children born a few years after a project is completed, as well as distance increases. So you really need to be quite close to an aid project. So to briefly skim through some of the past literature, as has already been mentioned, most previous studies have focused on population level, in other words, country level access to WASH services for evaluating aid effectiveness. And with regards to the effect of WASH aid on WASH services, the evidence is mixed. It's not super clear. Some of these papers have found negative results, some null results, some positive results. We think a better approach is instead to use subnational analyses. And so kind of try to leverage quasi-experimental variation in WASH aid. And these papers that have done this are less ambiguous. They tend to find positive effects of WASH aid on WASH services. And with regards to does WASH aid improve health outcomes, Bertram and Cainross suggest that aid interventions in WASH services may reduce diarrheal disease prevalence by up to 1/3, which in turn could have a pretty substantial effect on stunting. And Whalen 2017 finds that WASH aid is consistently associated with a reduction in mortality rates. So this is a pretty new literature. There's not a lot of papers, as has been mentioned, that look at the effect of aid, specifically WASH aid, on health. So we think this is kind of important early contribution of this paper. So going to the data, like I mentioned earlier, we use the aid data set, which contains all the geolocated WASH projects from Uganda's aid management platforms. So we don't have a lot at the end of the day. We only have 48 WASH projects built between 2009 and 2014, which have the very precise location of project. There's also not a huge amount of information on some of these projects, which is unfortunate. We were able to track down some of them. So for instance, on the right here is a picture of one of the boreholes included in our data set. But for only a small handful of the projects of these 48 can we learn a lot about the project itself. And this table just shows the staggered rollout of the projects. So the vast majority of aid projects, WASH aid projects, were completed between 2012 and 2013, with also a significant number in 2011. So this staggered rollout will kind of cause some interesting problems for our estimation strategy, which I'll talk about in a bit. And this is the map of WASH projects across Uganda. There are definitely some clusters. So you'll see a large cluster here, as well as around Kampala here. It's not a super high resolution image. But we do have important variation in terms of rural and urban. And you can see I have the population density shaded down here. So that's important to have. And for our household data, we use 6 waves of the Uganda National Panel Survey from 2005 to the most recent wave, 2015 to 2016. And this is an incredibly rich household survey. So it has information about household composition, characteristics, various resources they have, household wealth, health, and of course, child biometric data, which we need for our stunting measure, and as well as access to water and sanitation. And we're luckily able to get confidential data from the 2015-2016 survey from the Uganda Bureau of Statistics to exactly geolocate households. And I think this is kind of an important contribution here, because a lot of health surveys will add some random displacement to the household location, up to 10 kilometers in some cases, and we are able to precisely locate where these households are. So we don't have that displacement, and because WASH aid the effect seems to be highly localized, this is kind of an important thing we can contribute here. So we compute the distance of each household to each aid project, and we code the household as being located between 5 and 30 kilometers radius in 5-kilometer intervals. So those defined are various sort of treatment groups. And our sample is children under the age of 5. So this figure just shows the overall trends in stunting by region. As you can see, for all the regions except for Kampala, there's a pretty strong downward trend, which is good, but there's still substantial regional variation, even in the most recent survey wave. So the western region has a much higher prevalence of stunting compared to the northern regions. Great. So for the method, how do we actually get kind of a causal estimate of the effect of WASH aid on stunting? And we use the difference in differences design. So a lot of you are probably familiar with it, but if not, the general intuition is we want to compare the stunting rates before and after a project is completed in the treated households, which are those within, say, a 10-kilometer radius of a WASH project, to those stunting rates before and after a project is completed in the control households. So here, we're defining the control households to be all those that are 50 kilometers or more away, just to have kind of a consistent control group across all the treatment radiuses. But if you change the treatment group slightly, it doesn't affect the results too much. There's 2 main issues, though, with just doing like a standard diff and diff in this setting, though. So for the first one, we kind of, like I showed earlier, we have this staggered rollout of projects. And that makes it a little tricky to define a control group. So for instance, if you have a child who's 50 kilometers away and they were born in 2010, are they born 1 year before a 2011 project starts or 1 year after a 2009 project? And we want to align, the relative time that has passed since a project has been constructed. That's something that's a problem we need to solve. We also have this more kind of technical issue where, if the treatment effect in 1 year is different than the treatment effect in another year, that can basically bias our diff and diff estimate. So the strategy we choose to follow is the stack diff and diff approach of Zhangis et al. We steal that from the labor economics literature, and we think this does a pretty good job addressing both of these issues. I won't spend too much time on that, just so we can get through the main results, but we can talk about the method later. We also include household level controls to account for differences between households and try to help ensure a more apples to apples comparison. So yeah, I'll skip through this. So this figure kind of shows the overall results of our paper. So here, for each sort of treatment distance, we have plotted the stunting rate as well as the relative age of the child. And so the red bar is the year prior to a project completion. The green bar is the first year after a project completion. And the blue bar is sort of 2 years after project completion, even though it says 0 and 1. And basically what you see is a very sharp drop in that first year, in stunting rates in that first year after a project is completed, up to about 15 kilometers. After 15 kilometers, the drop is not nearly as sharp. And we also see, when you go to 2 years after project completion, the difference between the red bar and the blue bar is also much smaller. So this kind of anticipates what I'll show you in the diff and diff results, but we see that as sort of time passes, so as the cohort, as you look at children born 2 years after a project is completed, then you see you don't see as much of an effect of WASH aid projects. And also as the distance increases, you see that the effect sort of peters out. And like I said, this is just the first regression table where we're looking at just that cohort of children that are born right after a project is completed. So within 1 year, comparing it to the year before. And at 10 kilometers, we see a pretty substantial 21% drop in stunting rates for that cohort of children. When you move up to 15 kilometers, the estimated effect drops substantially to about 12%. Great. And so when we add older cohorts into the sample, or rather newer cohorts, so in the first table, we're adding cohorts of children that are born 2 years after a project, and in the bottom table, born 3 years after a project, the coefficients drop quite substantially in magnitude for the 10-kilometer point, and for the 15-kilometer point, they're no longer significant. So we find null effects once we include children that are born several years after a project completion. So just to summarize, for children born within 10 kilometers of an aid project, we find WASH aid reduces stunting by 14 to 21%. But for children born within 15 kilometers, the effect is about 11. Null distances of WASH aid for distances greater than 15K. And the effective intervention decreases as the age cohorts are expanded to include children born from 2 to 3 years after project completion. And so we kind of think that what's going on here is that after a year or so, once these projects are completed, there's some type of maintenance issue. That's kind of what we think might be happening, where the WASH aid projects, due to lack of funding or ability to fix them or something, kind of they have lower efficacy for reducing stunting for children born several years after completion. Right, and that's all I have. Thanks very much.
Well, thank you indeed. And yes, did you notice the similarities? But what about the WASH projects, and Sophia? We'll have to sort of discuss that afterwards, I think. I must say it's another interesting and in a way positive one. I'm not so surprised that projects that are 15, 20, 30 kilometers away don't have much impact, but because it's quite a long way to walk for water if that's what you need. But anyway, this is not for me to comment too much. I'd like to invite the three speakers up to the panel. We are going to eat into the lunchtime a little bit. We started 15 minutes late, so I'm still 15 minutes from the lunch. But that's what we'll be getting. And I believe, Mr. Hani, are you still online? Yes, according to the administrators here. Let me, why don't you bring your microphone? So we had two up there.
We need one for the audience?
Sorry?
A mic for the audience?
Yeah, she has one also.
Great.
So we are well endowed here. So who's first to ask questions here? We'll start in the very back. We start with the male there in the middle, and then the lady further away. Please.
Okay, I have comments for several papers. Thank you, first of all. Regarding Anna's paper, when you talk about existing literature, I thought you might also find some interesting results in the impact evaluation literature, like RCTs or other types of evaluations that focus more on specific programs, but that might be informative for your literature review. For Ryan, I was wondering about the, how should I say? No, sorry, that was the other one. Actually, that was a comment also to Anne. I was wondering about the pre-intervention balance between households that were close to the 8 project locations and those that were, in your estimation, not close, and to what extent they differed along observable household characteristics. And I thought, Ryan, just a comment, I think that has really cool implications for public management by differentiating between theft and saying, okay, part of it is just a public management task to ensure that the medicines should arrive where they should. And lastly, for the last presentation, I was wondering about, as far as I know, difference in difference, you need to satisfy the parallel trends assumption. Do you have some evidence on that? Thank you.
Oh, thanks a lot. That was very insightful and interesting. I have multiple comments too. So first to Anne-Sophie. Gulnaz Isabeko from the research. Sorry. Gulnaz Isabeko from the Research Center for East European Studies at the University of Bremen. To Anne-Sophie, the result you shared about the difference between multilateral and bilateral, this was interesting. I was wondering whether you could, does it have to do with the specific aspects of the projects? Or could that be also taken up a bit if we link it to, the difference between, for instance, the vertical programs? Does that mean that they work better? Or was there any role of budget support? And then I have some comments to Ryan. Your presentation was also very insightful too, and here I will probably differ in my comments to the previous. I was wondering with the audit, audit is always something very, very important to providers of aid. And for instance, just taking out of the case of Malawi, in the Kyrgyz Republic, there are cases of 9 reports being taken and noted by healthcare professionals in one medical facility just to make sure that they satisfy all criteria set by each provider. And each provider has different, that they have to make sure that they can report to GIZ or they report to Elsewhere, Global Fund, and many others. So the main problem of the papers you had doesn't have to do so much with the capacity per se, but the requirements that the providers have. So I was wondering, in the e-audit you provided, does this account for the harmonization? Is this like one audit for everyone, or are there like many of those? And is it possible to maybe, because it's such a great opportunity and you have many partners involved, to take, step up and go not just to audit, but like, let's say, procurement at the national level, if it is there, or maybe relate to that. So that could also maybe help out what you mentioned with stockouts. Because it's not only about how much is going to missing, but also to make sure that there is continuous supply. And it is difficult to keep records when you have to, fulfill everyone and everything around. I have multiple of others, but I won't probably mention them now. The last comment also to Ray, I think that relates to what you mentioned. I was wondering the role of infrastructure or like road conditions, if you consider that, referring to the distance, but that's it. Thanks.
Thank you. I think the one behind Anke. Yes.
Hi, everyone. I'm Heather. Thank you for the great presentations. A quick methods question for Anne-Sophie and Ryan, which is, do you need to consider aid projects on borders in neighboring countries within the radii of interest? So if there's something in Mozambique from Malawi that's within the 5-kilometer radius, do you need to deal with that somehow? But then I think on the bigger questions, Anne-Sophie, I'd be interested kind of on the potential implications of your findings for donors, IDPs, or countries themselves wanting to work effectively on the problem of stunting. I guess, how do you make sense of your sector results, and how you might sort of start to suggest that they rethink about what sectors to invest in from a problem focus rather than a sector focus. And then Ryan, I'm interested, these trackers sound fancy. I have no idea if they're expensive. Have you done kind of a cost effectiveness analysis? And then, what would be the pitch that you would make either to the company to work in a country like Malawi or to a donor that they should attach these to their projects? I guess the only question, since we've been talking so much about ownership, is the geocoded data. Have you ever this would just be interesting, how well do where projects are placed align with where national priorities are, or how much are they just look like wherever they wanted the donor, or the donors wanted them to go?
And the final one in this round, I think, Anke.
Thank you very much. This has been a super rich panel. I really enjoyed this. Thank you. So maybe following on from Heather, a question for Ryan. So this seems to open up a lot of possibilities for other sectors, you know. So have you planned some work there, some suggestions? I'd be curious. Question to Anne-Sophie was about the mechanism, because I think you've got a lot of different projects. So for example, education seemed to work on children's stunting, but you know, what sort of education helps 0 to 3-year-olds? What's the mechanism here? And maybe last question to Ray. So yeah, I mean, even 5 kilometers is a long way to sort of carry water. So again, I'm not really clear, you know, on these WASH projects, you know, what the exact, I mean, I love this sort of puzzling the data together, but I think it's now time to drill deeper in the next generation of work. And you've got 48 projects, so, you know, why not go there or get a Ugandan, you know, collaborate with a Ugandan university and actually look at these sort of maintenance issues, because I think you're really onto something there. Thank you.
I think, okay, I have one more hand. I'll do that as well. Otherwise.
Thank you. Really great panel, and I loved how the sort of different presentations fit together. I have a question, maybe a couple of questions for Ryan. I also thought this is like really promising and exciting, and I thought maybe asking you to reflect a little bit on the implications and kind of the next questions and hypotheses emerging from this finding that the theft is really like decentralized, and also maybe the label of theft is incorrect. And so then, you know, 2 questions thinking about like how do we actually stamp this out or reduce it even further. And something I was just wondering is, like, you showed the picture of your auditors with this thing in the backpack and they go wait around. I mean, do you think they were fully undetected? Like, were they I would be nervous. Like, was this putting people at risk potentially? And then if they are observed, you know, is there a sort of what Jonathan Fox calls like squeezing the balloon issue, where maybe it's reduced in that place? Then of course you can't observe what's happening in the other places, but maybe there are other forms of data collection. And then, I mean, there's trying to stamp this out, but then actually understanding like, why are people doing this? And sort of what is the, beyond this kind of monitoring, like what is the binding constraint or that leads people to engage in this behavior, however we want to label it, and then how might that be sort of addressed?
Well, thanks. Good questions, I think. I hope that you will be able to try to answer them. I start at the far end. Anne-Sophie, can you have the microphone, please?
Okay, so my notes, sorry.
I think you managed to get the
yeah, my
questions.
notes are a mess now, so I'll see if I can take it in order. From the far back, the first comment there about impact evaluation literature. Yeah, for sure. It's, I guess, we started from the kind of cross-country health literature and kind of brought it down to the meso level, rather. But, you know, there's the impact evaluation literature is obviously huge. So, of course, we should acknowledge that and discuss that in the paper. In terms of balance pre-interventions, yeah, I should present something of the sorts. It's it's a bit difficult since you have like variations sometimes within households as well. You can have one child, the mother is the respondent and she reports about her children. So you could have, in some cases you can have, ideally we would like to see that more so we can use that. But in some cases you have variation across siblings in treatment status, for instance. So the household variation is, you can't really use that, but we should present something along those lines for sure. So let's see, multilateral versus bilateral. Where did I have? Yeah, it was you. Yeah, sorry. Yeah, at this stage, I mean, again, I'm sorry to be a bit disappointing, but I guess our results are a little bit of a black box. we kind of we start again. Our starting point is rather the very aggregate national level literature and how we can disaggregate the analysis from that, and we kind of take steps in that direction. But still, if we, for example, if we want to break it down even further and look at individual donors and look at what projects are involved, we could, I guess, do that, and we could take more steps in that direction, but we go further and further away from the kind of large and quantitative literature. But I think that would actually be an interesting endeavor to do something along those lines, to actually dig into what problems, what actual projects are driving the results and so on. And in terms of what type of aid, we present this very briefly, just as, you know, it seems it's the multilateral aid driving the results. We don't really dig further into it. But just a comment on budget support, that's not even in the data, since we focus on projects with tangible project sites. So the budget support projects are not geocoded for natural reasons, since they're like distributed at the national level. So very unsatisfactory response to that one, I'm afraid. Yeah, what more? Consider aid projects on borders. We only consider the projects that are actually in the Malawi reported aid system. So if they're not in that, we don't include it. We don't have, I mean, there's geocoded aid data on a large scale for World Bank projects across neighboring countries, but it's only for selected recipient countries that you have this broad-based. It's Uganda, Malawi, and a couple of other places. How to make sense of the sector results? Yeah, again, that's one of those disappointing responses about a black box. Yeah, I think, as I was kind of getting at with the difference between multilateral and bilateral aid, it would be interesting to actually, as a next step, dig into what projects are involved. Maybe a hint to why we don't see any effect is, you know, what you're presenting about the health sector, because I was surprised by the health sector results, because there are so many health projects in the data. We don't have that many water and sanitation projects, but we have, like, I don't know how many, but many health projects. So I guess what we can do is make keyword search in the project descriptions for like child health or whatever, and see if we can narrow it down further and see if that explains things. Yeah, and that is kind of also linked to your question, Anke, about mechanism. We have some very preliminary analysis where we try to include right-hand side variables, different mechanism candidates. Actually, the estimated treatment effect is very stable across these, except for when including bed net use. So that's a candidate explanatory mechanism. In terms of, I think it's easier to actually explain why education sector or rural development sector aid should matter, rather than, you know, why health aid does not matter, in a sense. Because, you know, being better informed, even infrastructure projects being connected to markets or whatever could have positive effects on health outcomes in general, I guess. I'm taking up a long time now. Sorry.
Yes, we'll try to be shorter in terms of responses.
I'll try
You speak fast, I know.
Yes,
so
I know everyone is hungry, so I will do my best. Thanks everyone for these comments. We're still thinking through a lot of stuff on this paper. It's an early paper, so I appreciate these are all things we need to think about more. So let me just respond to a few of these. I think this question about different providers is a really interesting one. In Malawi, I don't think the problem is as severe as in the Kyrgyz Republic, but you do have multiple providers, particularly Global Fund is an independent provider, and they actually have their own delivery network independent of the government, which I think is somewhat ironic in that their numbers of missing medicines are actually higher than those in the government numbers, which I think is an ironic thing that I've always found somewhat tragically funny. But I think that this question about procurement is an important one. This is originally what we wanted to do, right? Is to try to track this at a much higher level as medicines go, you know, from the government side, from India to government warehouse, and then get distributed. This gets tricky both logistically and also there's some political things that just get a little dicey. I can talk about privately, but of course this would be a very interesting thing to do, and we've talked to a few people about moving in that direction. This question of, is it Heather? This question of pricing is a really interesting one. So I think, so this of course, you know, like most of these pilot projects was expensive, but if you look at, but think about what we're doing. So what we're doing is taking a small device that's worth about, $20. You can get smaller ones that are worth about $5, and putting on a device and to a random set of medicines and shipping it out to 200 clinics throughout Malawi. What does it cost to send a team of enumerators to 200 clinics in person with a car across bad roads to 200 clinics across Malawi? It is immensely more expensive than $2,000. So yes, it's expensive, but like compared to what is being spent on traditional forms of audits, this is much, much cheaper. Anka, this question of different sectors, I think, is a really interesting one. So I think we've, I'd be curious of your suggestions on what might be interesting to track here. I mean, we've talked to some people, particularly at the World Health Organization, about doing that kind of tracking. I think it'd be quite interesting. But I agree with you, right, that this, there's nothing about the health sector necessarily about the technology, right? That's potentially useful in a lot of areas. Ruth, we can chat longer about this. I think these questions about implications, of course, are crucial. I'm a political scientist, so I'm very interested in, like, what does this tell us about incentives? And I think as far as the auditor question, so we can talk more about the incentive question, but I think this question of auditors, so they're coming in, not identified, they look like local patients, right? They are coming from out of town, so sometimes they do get a second glance. I don't think we're getting these kind of spillover problems, in part because these are unannounced audits. People don't know they're coming. There's no way to anticipate this. Also, we're doing almost everywhere. We're doing 80% of clinics in southern Malawi. So if there's displacement, we're talking very, very, very small displacement. I don't see how that could happen unless they're incredibly coordinated. Okay, and calling each other, and then we can talk more about the rest.
Great. Yeah, I'll go quick. Also, thanks very much for your feedback. This is super useful. This is still a paper in progress, so it's great to hear. So for the first question regarding parallel trends, so we don't do this with the exact specification I presented today, but for an earlier specification, we do the typical kind of event study analysis where we look at 2 years prior to a project being completed and 3 years prior, and we don't see any evidence of a pre-trend there. Also, in our earlier paper, like I said, uses kind of the same data. We do some propensity score reweighting to get kind of a conditional parallel trends assumption that we were pretty confident in, and it doesn't affect our results too much. I think the second question was about road conditions and distance, and we didn't look at that. I don't know. There's no data, at least in what we had in our household surveys, which would give us much information about the local road conditions. You can make a case if there's like permanent differences in good quality roads. That variation would be kind of eaten up by the fixed effects in the model. But if there's like a particular month in a particular place that's especially rainy, that's something our model doesn't address. And for the 5 kilometers 10 kilometers even is an even further way to go. And I definitely agree. The issue is if we shrink kind of our radius too much, we just have like too few households in that radius to really, we do sometimes like was up there for, if you look at the 5 kilometer radius, you do see a stronger effect, but it's just not precise enough to say definitively. But for our earlier paper, we did find kind of like a unintuitive result where even if you were, even 10 kilometers away from an aid project, it would actually increase the amount of time that you would take to get water. Because people seem to, in that case, prefer going to the improved water source that's slightly further away rather than the less improved water source that's nearby. So I don't think it's, so that's kind of like an interesting quirk that we found. And yeah, I think anyone else?
No, thanks. Thank you. Thanks for the, Mr. Hani, there was no direct questions to your intervention. Don't know if you wish to add a sentence or two after listening to the other presentations. No sound. No sound? He's muted. Well, I don't think we will wait for that. I think we are hungry enough for lunch. So I wish to thank both Mr. Hani for his presentation, to the three of you who've been also answering, and for the good questions. And some of us will continue during lunchtime. Thanks a lot.
Oh.
I understand the data is about aid-supported water and wash. But when the government does it,